Okay, well, thank you for coming to our little presentation. From Drummond, I'm John Valutkevich. With me I have Tim Bennett. We'll do some introductions more formally, but again, we're going to talk a little bit about FHIR and demand across the industry. So we'll get right into it. So today we'd like to cover demand generators. When you think from a FHIR perspective, we're going to look at the drivers for FHIR app development, FHIR API development. So we'll break that up really largely into two categories. Tim will do a fair amount of that, especially as it relates to governmental. I'll break it down from the customer side and the demand side from basically the public, and then we'll bring it home for just some final wrap-up thoughts and have an opportunity for a quick Q&A. So Tim, I'll let you introduce yourself first.
Yeah, thanks, John. I'm Timothy Bennett. I'm the Director of Strategic Healthcare Initiatives at the Drummond Group. My role is to look in the place in the marketplace where testing, certification, has gaps and needs, and help build programs to address that. I've been with Drummond for almost 18 years now.
Great. And I'm John Valutkevich. I've been with Drummond 4 years now. Prior to that, spent about 20 years in the EHR product development industry as well as storage. And I'm charged with Director of Programs. So it's a lot of product, a lot of the ideas and go-to-market strategies, in particular looking at a FHIR app certification process new to the marketplace. We'll be leading the charge. And one of the things, among others, as it relates to FHIR compliance, testing, and certification, we're just right around the corner in the Drummond booth. So do come see us. So. A little bit about Drummond. Again, it's our 25th anniversary year. From an interoperability perspective, we're certainly a leader as far as healthcare IT. Started interoperability testing some 20-some-odd years ago with AS2, which is, Tim has a fair amount of background in that. But security and compliance standards, surrounding it with services as it relates to HIPAA, penetration testing, anything that has to do with interoperability from healthcare IT, from a Drummond perspective, we have that. We are the leading ONC ACB. We have had upwards of 3,500 attestations and accreditations for ONC certified products. Work with the payer industry as well, support CMS certification and HIPAA compliance assessments, as well as EPSC and SOC 2. So a lot of variety. Again, we're just around the corner from here, a deep-rooted history in interoperability and compliance training. So it made sense, obviously, to become an ONC ACB. So I'm going to turn it over to Tim, and he's going to break it up quickly. We're going to delve into two different areas of how we're going to look at FHIR demands. So Tim?
Yeah, sure, thanks. So certainly in recent years, the demand for FHIR enabled health IT technology has become increasingly in focus and importance. And these have come from primarily two different sectors. Certainly the government, who certainly has a mission to to push forward FHIR data interoperability between different systems in the healthcare organization, and they have been focusing on writing final rules and regulations in order to do that. And the other generators are coming from the users themselves, who are demanding, their own needs and use cases of getting access to health data and being able to use that to provide greater health care and improve patient health outcomes. So from a government standpoint, the final rules have gone back many years. I mean, there's been a focus on interoperability, been a focus on securely exchanging health data, going even back, probably to the 2014 edition of ONC's final rule on meaningful use, where they were first trying to push forward the direct project, exchanging CCDAs between providers, and then making patients have access to their health information. But as time went on, and as the FHIR technology began to mature, and it began to look like some of these implementation guides were taken front and center, like US Core, and APIs for being able to access this health information electronically. There were more and more final rules that began to take use from that. And then CMS also working with ONC were writing FHIR technology-enabled final rules to require payers to also use FHIR technology to exchange health data. And we see that emerging with TEFCA, and we know that there's more rules coming down the pike, both on the CMS side and the ONC side as well.
Great. All right, so what I'm going to do is take a look from a use case and look at the FHIR industry and adoption for FHIR. I'm going to break it up into really three main categories when you think about it, and I'll explain. First, we'll focus on the EHR developer side. So they're a big part of this equation with FHIR app development, obviously. And then again, there's the payer side as well. So hot on the heels of Health and Human Services and ONC requirements, we have the CMS requirements driving the payers as well. And then I'm going to look at the third part of the equation is, those are the rich data sources. So what about the apps and what about the use cases and the developers that are filling with niche or bolt-on applications and their story and how they are actually pushing demand for FHIR products too. And within this, I'm going to break it up and say, well, there's the demand portion of it, but then let's just be honest with each other. You look back at the recent Journal of American Medicine articles, the challenges with adoption are out there, and we're going to highlight some of those as well. So when you think about the demand for the EHR developer and supporting use cases, we'll take a look at a couple here. First of all is the clinical workflows. They are a rich data source, right? And a fair amount of these rich data sources expect and support bidirectional FHIR exchange. Of course, they've had to open up their API for ONC rules and regulations, but they too obviously still want to be a valued source of truth. So they write their own FHIR apps to go out and bring data back so that they can use them within the walls of the applications. Then there's obviously the additional administrative tasks, and you think about this kiosks, you think about the payer models, and you think about some of the workflows that help out the general administrative department. So we've seen an explosion of innovation around additional workflows that the large EHR as a data source, even with 40 some odd applications, may not actually be able to capture. Don't forget about the patient access. We've seen a move and a classification of, well, all patients have access to an app. More likely, it's a web portal that's available on its phone, but we are seeing this migration to the fact that we all are used to using apps on our phone, so why can't we use it for patient access? Researchers and developers, right? EHRs in particular have a demand from research and development, whether it's oncology, whether it's specialized genomics. Open up your API and we'll do that specialty work, again, via apps. And then obviously there is the health information exchange as a part of that, and other research organizations. So there's that demand on the EHR developer's doorstep to open up. So what are the challenges though? Okay, so if we put the EHR hat on for a minute or two, there's the management of the app demand. The larger EHRs, the rich data sources, obviously have an attractive amount of data and are a target for, and I use that word specifically, not nefariously, for an app developer to say, it would be good for me to connect, you would satisfy my client base if I have access to your data, right? The challenge, obviously, is information blocking. I can attest to, from friends in the EHR industry, that they are frightened to death of information blocking. Even though the folks that have been largely penalized for information blocking are the providers. It's not been the EHRs. But the point of the matter is, they've had to open up their API with stipulations sometimes, or at your free will, at your own risk. So information blocking has fueled demand for APIs to be opened up by product developers. Security is a concern. Of course, any app developer going through the G10 compliance requirements, okay, there's the secure exchanges built into it, smart on FHIR launch, so you're covered there. But think about the equation of, well, what happens to the data on the other side? The EHR developer community is rightly so. We've seen some incidents that an app developer will take that data, and do they necessarily do a good job with that data once they retrieve it? Are they going to codify meds, allergies, and problems and do proper reconciliation? And then finally, I think if all of us are familiar with browsing an app store, whether it is from an EHR developer or on a smart on FHIR store, you will see hundreds of products in some cases. How do you differentiate between which one's good? They all have a data sheet. They all say they might do the same thing. I've seen app stores with 4 and 5 different cardiology apps within it. Well, which one should I use? It's only as good as the screenshot and the initial documentation. So there's a differentiator there. that needs to be accounted for. And then finally is all of that demand, it's expensive. As many of you probably know, EHR developers, they're not churning them out of college right away. It's a field-based experience. So it's an expensive resource to tie up in a large EHR, fielding a lot of questions. So we have to think about that. The payer demand is very much similar to the EHR side. Again, a rich data source. Again, sometimes bi-directional in that they have their own apps going out and getting data. We'll see more of that with payer and payer exchange. But patients had to, by CMS ruling a year and a half ago, have access to patient data from payers. Hasn't been a huge uptick in it because I just don't think a lot of patients even know about it, and there are very few apps that conglomerate all that together. Clinicians themselves certainly do benefit from understanding the history from a payer perspective, and there are large IDNs that are based on a model of the EHR hospital, ambulatory, home health side, sharing information and being the payer itself. And then finally, researchers and developments can certainly benefit from a large swath of data from a population that might be in a large statewide HMO. So again, a rich data source. But we'll acknowledge again, there's challenges that the payers face. That, everybody has an app, I should be able to connect. A lot of challenges on their side too. We have seen from our experience, especially with the certification program we have, that there's a big decision for payers to make to do a build versus buy. There's a fair amount of app developers out there that offer a pretty good buy decision, but you have to do a lot of vetting with that. And you have to go through the process of finding the right one and the right fit, and then the enabling of your FHIR data. Payer systems have a bit of ways to go to enable FHIR data where the EHRs were a bit ahead of the curve. So there's that. And then there is, as opposed to information blocking with the ONC side, CMS enforcement. It's real. CMS has mandated that the APIs be open at least to payers at this particular point in time, and now we're going to go forward with prior auth and all. And there is enforcement activity that can occur from CMS if a payer doesn't enable that data. So there's a bit of a hurry up and wait there as well. And then there is that client base. Similar to the EHR community, it's like, how do I really know what that client's going to do with the data? So there's the challenges. Now again, I don't want to badmouth the FHIR app developers. I got friends who are, and they have their challenges as well. And if I was to outline it this way, when you think of the FHIR app developer end use case, right? Obviously there's the clinicians. There are some really slick bolt-on, phone-based, tablet-based apps that plug and play really well into major EHR systems. So there is that. From a patient perspective, of course, yes, we consider ourselves, oh, I have an app for that. If I access it from my phone. It may be a glorified web link to an original web portal, but it's still an app. So the demand is there, to a degree. Researchers and developers, again, having and developing their own apps to go after the rich data sources, rightly so, as talked about in the EHR section. And then finally, from an administrative perspective, again, I'm in the kiosk business, or I'm in the bill pay business, or I'm in the patient population business. App development certainly bodes well to say that I can get good information across multiple EHRs, for instance, or payers. But here's their challenges, and we'll commiserate a bit with the app developers on this, is there's nothing right now, and I'm just going to get very frank with you, there's nothing to prevent some Tom, Dick, and Harry from in his garage coding a FHIR app. That's the easy part. The IGs are there, the SDKs are there, and you can code a FHIR app. Great. The thing of it is when you're pitching that app, and the challenge is understanding what use case are you really trying to fulfill. And it gets tricky when you differentiate between clinician workflows and administrative workflows. So you have that. Also too, if I'm an app developer right now, plan for repetitive testing. And 8 times out of 10 on average, the statistic is, if I'm an app developer, I'm a small shop. So I have expensive resources or contracted resources that are going to have to do iterative testing from data source to data source. It would be nice if I could kind of go somewhere, get verified, and then it would be easier to plug and play. That is not the case right now. Address security, okay? Obviously it's built into the main specifications, we all know that. But again, the security that I'm talking about is the security of the data that you as an actor grab from a rich data source. What do you do with it? How can you assure the organization you're connecting with that you're a good actor with that data? Talked a little bit about this earlier too, is most app stores have hundreds of listings. What makes your 1 of 7 cardiology or 8 or 9, 10 hypertension apps, what makes yours better than just a pretty screen splash and a data sheet? So how can you go throughout industry, through connectathons and other organizations to prove that you have actually a good app? And this is something that you probably don't want to hear people say at a large organization like this, but I'll say this too, because I'm crazy. Don't be a disruptor. And what I mean by that is, think of the clinician audience and the administrative audience. They had their lives majorly disrupted with meaningful use going back many years ago. And then obviously through the meaningful use 1, 2, and 3, and the rest of it. Everything now had been disrupted by applications. So what you do want to be is you want to be cognizant that you might have a great product idea as an app developer. But if a clinician or administrative person has to do one extra click, has to wait for an update, or determine that your app works really great with VHRA, but as soon as I pointed it at EHRB, it doesn't work, you're going to lose market share, and that's the challenge. So hopefully up to this point, what I've done here between myself and Tim is say, when you think about the demands and the generators of interest in the FHIR market, there's the rich data sources and the drivers, and government is part of that equation. And then again is this whole ecosystem that surrounds it that says there are niches and workflows to be filled, and there's patient, administrative, and clinical tasks that could be filled by FHIR. Now we just have to really get to it. And again, I think there's been a number of different articles. I'll cite the one for the Journal of American Management Information that came out about a week or two ago that ONC sponsored. And the challenges that are there for connectivity. It's a really good read. So I'm going to pass it off to Tim. He's going to bring it home and put a dot on this, and then we'll be available for a few minutes for a couple of questions. Tim?
Yeah, thanks, John. So just to kind of wrap up a few final thoughts. So as far as where we're kind of going, I mean, there's more final rules to come. There's more use cases to come, and that's just going to differentiate the market even more, in the needs for developers to be able to be nimble, to be reactive to where the market is going, where the government is pushing it. Some of the more important use cases we're on the verge in the next few years of really seeing, being realized. Things like prior authorization, addressing the No Surprises Act, where patients can, finally get a true understanding of what the cost of their health care is going to be, before they have to have the procedure. And that's going to take a lot of complicated electronic conversations between payers and providers to even, provide that. And FHIR will be at the forefront of that. And I imagine, just in my own mind, that FHIR apps will help providers be able to do that, have those conversations on the fly with payers in order, if you can imagine, if I'm going to have a procedure that's going to involve multiple providers, all of those providers have to be able to funnel up their estimates along with the payer in order to get that to the patient. So that's just an example of some complicated choreography that's going to have to happen in the FHIR space, and you're not going to be able to just rely on sort of institutional systems to be able to do that. You're going to have FHIR apps in the hands of people to be able to respond to that and be able to handle those conversations. And so I'm seeing that these use cases coming down the road, having FHIR apps, ones that are going to be able to be used by both patients and the payers, are going to be key to that. And with that, security is going to have to be a premium, and interoperability is going to have to be a premium, and ultimately, I think there has to be some sort of way to know in the marketplace which of these apps are good actors and which ones are not. So with that, John, I think we'll wrap it up for Q&A.
Yeah, so just touch it off again. So again, Tim and I from the Drummond Group are happy to be here in the Interop Showcase. And again, as a ONC ACB, certainly have insight into a lot of this. And again, from a FHIR app differentiator perspective, the thought process to say that it's crowded out there. There's a lot of competition. Innovation is happening. It's happening today. It's happening tomorrow. It's been going on for a long period of time. So from a differentiator perspective is, how do you cut through the noise? So there's some considerations there, I think, from a research, design, development, and implementation perspective. So we have a microphone and happy to take some questions. It's recorded, so I'm going to walk around with it and we'll go from there. I'll start over here.
Hi there, I'm good, thank you. From Drummond's perspective, what actually are you testing the EHR vendors on as it relates to FHIR when they come in and get their certification? Are you testing to see that they actually have FHIR endpoints available for all of their participants and that there's actually FHIR resources behind the FHIR endpoints? Are you testing that so that I can feel confident I can go out and check at every EHR vendor and say, Drummond is certified and we have a FHIR endpoint here and we also have FHIR resources?
That's a good one.
Yeah, that's a good question. I mean, as an ONC ACB that tests in that domain, you're really talking about the patient access APIs for G10, right? Yeah, okay. Yeah. So there's certain things that as a tester we can test as part of the ONC certification program. I'll be honest with you, there's areas outside of what the certification requirements mandated by ONC are that are what I would call gray areas. And sometimes ONC thinks that they'll get cleaned up in real world testing and things like that, but I think what we're finding out, we're now sort of, when was the G10 deadline? Was it
last December?
It was a year ago December, and I think what we're kind of seeing in the wake of that is that as clients begin to try to connect to EHR systems, that some EHR systems were able to pass tests, but when they're in the real world, maybe they don't work quite like they did in a clean lab sort of test like Drummond Group does. And so I know we've seen some areas where no, endpoints aren't published, they're not working, and there are client there are client apps out there that are starting to raise noise about that, and so I think that's going to be a new level, or that'll be something that's going to be addressed, in the next year or two to come. So I think that there's a gap in that area of what's really working in the real world versus what was tested and certified.
I'm sorry, go ahead, Steve.
Well, we'll come back. There's plenty of time.
Laura and I will be here all day. Data quality. What are you guys doing? I mean, finding the endpoints is great, but what are you doing in terms of looking at the data that you're getting in the APIs and assessing the quality? And are you thinking of collaborating with D.D. Davis at Sequoia Project, on looking at FHIR data quality?
Yeah, that's a great question. One of the things that Drummond doesn't test is, the quality of the data that comes back. It's mostly just, are you conformant with the FHIR standard, and that's something that internally we have been talking about, and certainly I think collaboration is a great way to do it, because I'm not sure anyone can just do it on their own. But with the emergence of synthetic data and ways to be able to build, because here's the thing, in those testing and certification programs, the developers get to bring their own data. And so they get to make up the data and bring it, and then they can test and get certified. But what you really need to do is you need to be able to push data to them that's known from the testing and certification group, and then be able to make sure that you're getting that correct data back, because and that's, I think that's a gap right now. Yeah. Any other questions?
Yes, ma'am.
Yeah.
So So what are you thinking on the FHIR resources in terms of testing those? Those have to be in place by 2027. So as you start testing the EHR vendors on their FHIR endpoints and their FHIR resources actually being available, right? Actually being there. What are your expectations really on when you're going to have that available at Drummond and start doing that testing?
Well, so a couple of years we started a program to test the payers on the patient, access resources from their perspective, and that's been a whole nother challenge. And now we're going to be moving towards what we're calling interoperability tests. To get ready for the 2027 deadline, where we're actually going to bring these real systems together and have them test with each other. We did this, John sort of went through the history of Drummond, 25 years ago. That's where we sort of got our start, is doing interoperability testing in the supply chain and other domains, financials, automotive, doing secure data exchange over the internet. And we established sort of a automated platform to be able to bring products together, and they actually test with each other so that you can know these products are actually interoperable with each other. And we're going to do that for FHIR. That's something that we're starting this year, and that's going to, because we know with these more complicated use cases like prior authorization, patient cost transparency, payer-payer data exchange, you're going to have more of these EHRs and payers being able to exchange data. And if no one knows that they're interoperable with each other, if these FHIR resources really are there or not just you bring it to a test lab, you do some conformance testing, you're able to do that. But when you actually have to test, with data with other systems, I think it's going to, that's a gap right now. We don't see that happening. And we're going to try to jump in and fill that. That's where I think we'll be able to tighten up that in the real systems. And
think about right now the real world testing agenda. It's pretty open, and you can get away with, and I say get away with, I don't mean this disparagingly at all, because my background is in EHR development, is just tracking who's deployed. And it's like, well, what's a good number? I got 2 or 3 really aggressive customers. Yeah, but your footprint is nationwide. Why don't you have? So the real world testing rules presently for the last few years have left it wide open in terms of what you have to document and what you actually have to prove. So we would certainly be all for a more stringent, measured approach to say there's expectations behind this and that you should be able to produce X%, or get into a matrix with a couple of vendors and have your system, quote unquote, always on at certain times of the year, and you should be able to demonstrate that you're transacting. So it's a really excellent question. So we'll see. There needs the carrot and stick approach continues to be, but it has been minimal for the last couple of years to push forward innovation. And with innovation comes financial backing and wherewithal to do it. And then there are small app developers that want to play in that equation too. So yeah, it should be interesting. One more question, and then we are getting the red light. Okay. Well, we'll be here, and again, we have a good-sized booth right here just behind us. So any questions as it relates to FHIR apps, matrix testing, interoperability as it relates to FHIR app development, feel free to come see us. We're going to be here all week. All right, don't forget to tip your waiters and waitresses. Thank you.